Hello friends, today we are going to discuss regarding investigations in a patient with MINOCA. Since MINOCA is a working diagnosis, first we have to rule out mimics. Number 1, cardiac troponins. So there may be rise and fall pattern in troponins which may indicate towards myocardial injury. It can also help to distinguish between acute and chronic elevation. Number 2, ECG changes. So we may look for ECG changes in the form of ST segment depression, ST segment elevation, T wave inversion or Q waves. Number 3, to rule out other causes of troponin elevation in the form of sepsis, anemia, renal dysfunction, myocarditis or thromboembolism. Then we have to assess coronary anatomy. So in order to coronary anatomy, we may go for number 1, coronary angiography. So in a patient of MINOCA, coronary angiography shows less than 50% stenosis in epicardial coronary arteries. It helps to rule out obstructive CAD. It helps to identify the mechanism, that is, whether it is due to plaque disruption or vasospasm or if there is any distal thrombus. Then we may also go for intravascular imaging in the form of IVUS or OCT. Even if angiography is normal, the micro plaque event may still exist, which can be identified via IVUS or OCT. In OCT, plaque disruption or spontaneous coronary artery dissection can be visible, and in IVUS, intramural thrombus can be seen as it has deeper penetration. So approximately 40% of the cases can be diagnosed using IVUS or OCT. Number 3, cardiac MRI. So cardiac MRI should ideally be done within 1 to 2 weeks. It helps to identify myocardial infarction, myocarditis, Tokushubu cardiomyopathy or infiltrative disorder, that is sarcoid or amyloid. Cardiac MRI will provide answer in approximately 75 to 90% of the cases of MINOCA. Then we have to evaluate for the source of cardiac embolism. Investigation may include echocardiography. So echocardiography will help to assess LV dysfunction, regional wall motion abnormality, LV thrombus. Then ECG and Holter will help to identify whether there is any atrial fibrillation, to detect atrial fibrillation. Then we have to assess for hypercoagulable states. To rule out hypercoagulable states like antiphospholipid syndrome, factor V Leiden mutation, protein S and protein C deficiency. And at last, finally, we have to consider CT angiography. So CT coronary angiography is considered when invasive test is not feasible. It is especially useful in cases of spontaneous dissection of coronary artery and anomalous coronaries. Thank you.